Greetings from Believers Institute of Renal Disease. I'm Dr. Geo Philip John, consultant nephrologist at Believers Church Medical College Hospital, Tiruvalla. The theme for this year's World Kidney Day is Living Well with Kidney Disease. Today, in this session, we will try to get a brief idea about the immunosuppressants we use in renal transplant. So, there are two types of renal transplant. One is ABO-compatible renal transplant. The second one is ABO-incompatible renal transplant. The ABO-incompatible renal transplant requires higher levels of immunosuppression, including plasmapheresis or immunoadsorption, IVIG, and rituximab, in addition to the immunosuppression that we commonly use in ABO-compatible transplant. So there are two main components of immunosuppression. The first one is induction, and the second one is maintenance immunosuppression. The induction, two agents are used, basiliximab and polyclonal antithymocyte globulin or ATG. Basiliximab is a chimeric monoclonal antibody which inhibits the interleukin-2 receptor. It's usually given at a dose of 20 milligram IV on post-op day 0 and post-op day 4. It's a relatively safe drug without much adverse effects. Polyclonal antithymocyte globulin or ATG, there are two types. One is equine ATG or NGAP, and the second one is rapid ATG or thymoglobulin. This is used especially for patients with high immunological risk, like patients with high PRA or donor-specific antibodies, or patients with 5 to 6 HLA mismatch, or patients with previous multiple renal transplants, or the previous renal transplant was lost due to an immunological cause. After the induction phase, after the surgery, there comes the importance of the maintenance immunosuppression. The commonly used one is triple immunosuppression with steroids, calcineurin inhibitors, and mycophenolate mofetil or mycophenolate sodium. The steroids, IV methylprednisolone, is usually used in the induction phase, and then later it is converted to oral prednisolone. The calcineurin inhibitors commonly used is tacrolimus and cyclosporine, more commonly the tacrolimus. These drugs have a narrow therapeutic index, so a close drug monitoring is required in most instances. These drugs are metabolized by cytochrome 3A4, so drugs that can affect the cytochrome 3A4 can increase or decrease the levels of calcineurin inhibitors, thereby increasing the chance of calcineurin toxicity, or patients can have rejection when the levels are on the lower side. The third agent used in triple immunosuppression is mycophenolate mofetil or mycophenolate sodium, which is an anti-proliferative agent. It is the active metabolite of this drug is mycophenolic acid, and it reversibly inhibits the inosine monophosphate dehydrogenase and thereby inhibits the synthesis of guanosine monophosphate. So this agent is important in the triple immunosuppression of renal transplant patients. These are the commonly used drugs in an ABO incompatible renal transplant. Hope you had a brief idea about the drugs which we use in ABO compatible renal transplant. Thank you. Take care.